So this is the backstory over the last sort of 30 or 40 years. So go back into the 80s, this will be familiar to us. Back in the 80s, there was no choice of screening really, it was just amnio versus no amnio. And then thankfully we moved towards screening. In the 90s, we had these, people will be familiar with these second trimester serum screening triple test and the quad test. And if people didn't want that, they could have a CVS or an amniocentesis. And then sort of in the early 90s was the big revolution. So this is Professor Nicolaides in London, who's a world authority. So he invented effectively this nuchal translucency. So from about the mid-90s, nuchal translucency has become kind of the mainstay of screening around the world, or for people who decline nuchal translucency, a CVS or amniocentesis. And now over the last couple of years, we have this cell-free DNA concept, this NIPT, which is going to be the focus of today's talk. So it's been really sort of a changing over the last few decades. So this slide will be familiar to people, and I put it in here really just to focus on, obviously we know that the risk of Down syndrome, which is trisomy 21, and Edwards syndrome and Pate syndrome, the three main chromosome risks, we know the risk goes up as the woman gets older. But just to point out, because what we're seeing with this NIPT, we're picking up now some sex chromosome abnormalities, which we never picked up before. And just to point out that sex chromosome abnormalities, like Turner syndrome or XXX, the risk does not change. So the risk is standard across ages. And this is important when you start talking about NIPT. But approximately a 40-year-old woman has about a 1% chance of a baby with Down syndrome. That's the sort of ballpark figure. I can see figures there. It's just good to keep a few in your mind so you can say to the patients, about 1 in 350 when you're 35 and about 1 in 100 when you're 40. And you can kind of work the rest out. So the traditional screening, what we call nuchal translucency screening, or technically combined first trimester screening, this is what we've been doing for the last 20 years, and we're still doing it. And it's sometimes called the nuchal translucency test. And the nuchal translucency, as you know, is this little film of fluid at the back of the neck. You can see on the scan nicely there. So the lower white line is the skin on the back of baby's neck, and the black just superficial to that is the little nuchal translucencies that all babies have, but babies with chromosomal abnormalities, it tends to be a bit thicker. So you measure that in millimeters, and then you combine it with the woman's age and with the blood tests, and you get the risk of Downs, Edwards, and Pates. And because this is such an important measurement, it's quite strictly controlled in fetal medicine and in obstetrics who can perform these measurements. And in the UK, it's the Fetal Medicine Foundation. And in Australia, anyone actually doing these scans needs to be certified and needs to send their pictures in once a year that are then audited by someone independent just to make sure that they're measuring it correctly. So there's quite a high level of quality control in the system. And this is the original publication back in '92, the very first publication to talk about nuchal translucency. So as I said, we combine this measurement with the serum biochemistry, which are the blood tests that the mother has. And then you get this kind of a result. So the result gives you her background risk, which is based on her age and whether or not she's had a previous baby with a chromosomal problem. They're the two things that affect her background risk. And then you give her her new adjusted risk based on the new information. And the woman is given a 1 in X risk, a numerical probability for Down syndrome, Edwards syndrome, and Pate syndrome. Sometimes you combine Edwards and Pates together. Okay. And we know that in the general population, about 5% of women, that's pretty standard in the different studies, about 5% of women will receive a high-risk result if you set your cutoff at 1 in 300 or higher. So the test is designed so that about 5% of women will get a high-risk result. So I've just put this in. This was actually a comment made at a conference I was at last year overseas, and obviously there's a whole day on NIPT testing, and someone just made the sort of straightforward comment, but it's got good insight that really the patients, they talk about Down syndrome because they haven't heard of the other syndromes. But actually, when a patient comes in to me and says, does my baby have Down syndrome, really what they want to know is that their baby is healthy. And that does become relevant when you're trying to compare the nuchal translucency with the NIPT, because they are looking for slightly different things. There are pros and cons to both. So just to keep this in mind, it's not all about Down syndrome. There are other things, structural and chromosomal, that we are looking for. So these are the sort of models, the nuchal translucency models. The most basic one is the age and the measurements and the two bloods. This is the standard one, PAP-A and HCG. And this detects about 85% of babies with Downs. And then you can add the nasal bone, as is routinely done these days, and that you improve your detection rate. And then you can add in ductus venosus and a few fancy measurements. And then increasingly, some of the laboratories are reporting placental growth factor. So as the test has evolved, we've added on a couple of extra bloods and a couple of extra ultrasound markers. And overall, with nuchal translucency, you can achieve a detection rate of about 90 to 95% of babies. And by detection rate, those women will receive a high-risk result. So the nuchal translucency test will flag a high-risk result, giving the woman the opportunity to go and have a diagnostic test. And the false positive rate, the chance that the woman gets unnecessary anxiety and receives a high-risk result, even though the baby is chromosomally healthy, is somewhere between about 2 to 3%. Okay, so they're sort of standard figures, and they're good to keep in mind again when we're comparing it to the NIPT test. This is how the test does for the other chromosomal problems. So Edwards syndrome, it's not quite as good. It's about 80%. Pate syndrome, which is trisomy 13, these are second and third most common, really lethal chromosomal abnormalities, much more severe than Downs, is 66%. And nuchal translucency per se does not give a risk for Turner syndrome, but we know that most babies with Turner syndrome will have this cystic hygroma, which is like a big nuchal translucency. So indirectly, you'll pick them up through the nuchal translucency test, even though you're not actually giving them a figure. You'll pick up about 3/4 because the babies look abnormal on scan. So they're the kind of detection rates, and you can see the false positive rates. So people often say about nuchal translucency, don't all babies have big nuchals? And that's true. You know, the nuchal is, whether the nuchal is small or big doesn't discriminate between the different problems. And then the different pattern of bloods discriminates as to what the result is high risk for. So the classic pattern with Downs is a high HCG, whereas with Edwards it's a low HCG. So this is how the computer works out whether or not it spits out a high result for all three or for one or for two, because all of these chromosomal problems are associated with big nuchals. So this is important. What are the other benefits of nuchal translucency screening? Because this is where it differentiates from the cell-free DNA testing, which we'll talk about. So the first thing is that the nuchal translucency measurement itself, that measurement in millimeters, can be associated with the risk of other chromosomal abnormalities, not these three most common ones, other rarer problems. And I'll talk about these in turn. The second issue is that it can be associated with heart problems. Third issue is we get an early look at the baby and make sure the baby looks nice and healthy at 12, 13 weeks. And the last issue is about the Pate blood test. So just look at the first one. This is quite a big study recently published last year in the New England Journal, and I'm going to come back to this later because this was a study actually comparing nuchal translucency and cell-free DNA testing. But I'm not including it here to compare it. We'll talk about it later. But I'm just including it here because as part of this study, they did nuchal translucency testing, or combined first trimester screening, in almost 16,000 women. And of those women, 6%, so that sort of typical 5%, 6% received a high-risk result. And overall, 1 in 250 women in this group who had nuchal translucencies had a baby with a chromosomal problem, aneuploidy. So there's 68 cases of aneuploidy. And when you break the aneuploidy down, most were Downs, as you'd expect. These were trisomy 13 and 18. But the other kind of 20, 25% were so-called atypical chromosomal abnormalities that would not be detected. So if all these women had NIPT, you would have missed these 25%, which the nuchal translucency test successfully identified by giving a high-risk result. The women then went and had a CVS or amnio, and then they were given a result of a translocation or Turner's. So just remember that a big nuchal sometimes leads us to diagnose a chromosomal abnormality, which is not Downs or Edwards or Pate. So that's quite important to remember. The second benefit is we know that big babies with big nuchal translucencies, which is usually defined as above, usually 3 millimeters is our cutoff. That represents about 2% of the population. 3.5 represents about 1% of the population. We know that if a baby has a big nuchal on scan, and if the baby's chromosomes are tested and are found to be healthy, because most babies with a nuchal of 4 millimeters will have normal chromosomes, then we know that these babies have a significantly increased chance of a congenital cardiac problem. So about 1 in 100 babies overall actually will have a congenital heart problem, usually just a minor VSD, but sometimes it can be more significant, tetralogy or hypoplastic left heart. Something more significant maybe needs surgical intervention postnatally. And as the nuchal gets bigger, it's a bit small, but you can see as the nuchal gets bigger, 3.5, 4.5, 5.5, 6.5, the rate of cardiac defects per 1,000 goes up, 7.5%, 15%, 20%, 65%. So from our point of view, we see a big nuchal, we think about chromosomes, and if chromosomes are normal or if the patient declines testing, you must start having a look at that heart, in particular at 16 weeks and 19 weeks, and maybe even again at 23 weeks. And that
Why is that? Why does it show up and then...
Why is that? Well, actually, no one really fully knows why the nuchal translucency is big in babies with Down syndrome, but one of the theories is almost early heart failure, in the same way as someone who's 80 gets peripheral edema. Babies obviously aren't standing up. The feeling is that the nuchal may represent almost dependent edema, may represent lymphedema or abnormal lymphatic drainage. So there's various different theories. No one's fully sort of au fait with it. Even the
interesting that it's within a narrow window period.
The 11 to 13 plus 6. I think the 11 to 13 plus 6 was picked on purpose when it was first designed because they wanted a gestation at which, if you found you had a big nuchal, you could offer an invasive test, and you can't do a CVS before 11 weeks. And once the baby gets more than 14 weeks, the baby, as you know, tends to be a flex and extend, so it's harder to get the measurement. So that's why it was sort of picked, because to fulfill screening criteria, you have to be able to offer a diagnostic test. So I think that's where the 11 to 14 came from.
Looking at subsequent outcome, you know, if you've got an aneuploidy of some sort, you may or may not have termination.
Yes.
But with a cardiac defect, it's less likely, and would it matter if it waited till the 18 weeks morphology scan to make
Yeah.
a determination?
You're right. You're right. So, I mean, what we're going to look at now is sort of, you know, what abnormalities can you pick up at 12 or 13 weeks? The counter-argument is that many of these would be picked up anyway.
Yeah.
Now, you're trying to trade off the early information, perhaps with some uncertainty. We need to have another look anyway.
Yeah, that's what I'm
So,
saying.
so
Well, you just-
you're right.
yeah.
So it is a trade-off. But I mean, that leads me on nicely to this slide. As the machines, as Talat said, the machines are getting better, and we're getting better at scanning babies earlier and earlier. And, you know, when you see a couple who've maybe had a test at 10 weeks, a harmony test, and then come back at 19 weeks and to be told their baby has spina bifida, hyperplastic left heart, it's a big shock. So it is nice sometimes to be able to give them the information earlier. And actually our detection rates on early anatomy scans, whether that's 13, 14, 15 weeks, are quite good. You know, there's figures on the right-hand column there. Overall, we pick up maybe 2/3 of defects. You know, we pick up big omphalocele there. You can see the bowel outside the tummy. That's a huge big bladder. That's a cephalocele. That baby had a Meckel-Gruber syndrome. Twins, that's a hyperplastic left heart. So these are all pictures, you know, sort of 13, 14, 15 weeks. And sometimes you have to say, let's come back in a couple of weeks and the picture will evolve, you're right. But other times you can offer the amniocentesis at the 15.5 weeks and sort of get the management moving forward. And then the last issue, which I think is probably a non-starter, but people talk about, is this concept of a PAP-A. You know, PAP-A is one of the bloods, pregnancy-associated plasma protein A, one of the standard bloods that's done as part of the nuchal. And we know that babies with Down syndrome and Patau syndrome and Edwards syndrome often have very low PAP-As. And then because PAP-A was being done on so many women, they started working out that, well, the women who have a low PAP-A but whose babies are healthy have higher rates of growth restriction. And it is true, you know, if a woman has a PAP-A level as a multiple of the median that comes back in the bottom 5th percentile, so that's usually about 0.4 or less, it's true that her baby is twice as likely to be small. You know, we call the bottom 10% of babies small, and if you have a low PAP-A, the chance of your baby being small is about 20%. You know, and you might give her aspirin, you watch the baby's growth, etc. But PAP-A was never designed as population screening. So the idea that we have to include PAP-A even if you have a harmony test or NIPT test, you know, that's not really been the concept. People just like having PAP-A results, but it doesn't mean everyone has to have a PAP-A, you know. But some people argue that, oh, you must have PAP-A. How could we live without it, you know? Didn't exist 30 years ago and people lived without it. So. If we see a low PAP-A, we won't ignore it, but the idea that every pregnant woman who chooses not to have nuchal transducing screening must have a PAP-A level.
But does it alter the management in routine pregnancy if someone's coming with their PT scan with a low PAP-A? Does
Yeah.
it to flick them to the high-risk clinic or something?
So if you see a woman and she has, say, if you see a woman and her overall risk of Downs is not too particularly bad, but the PAP-A stands out as being 0.3 moms, you'll probably say she needs a 32 or 34-week ultrasound, basically, you know. So it probably does alter management.
Isn't it necessary to do this test automatically on the day you are getting the nuchal transference done for the calculation?
Well, the bloods often take 24 hours. So ideally, the ideal setup, and this is not the setup we do in Royal North Shore, but what most of the private practices do is they'll ask the woman to have the bloods done a couple of days before. So when you see the patient, you have the blood results, you do the nuchal scan, you check the nasal bone, and you produce the result. It doesn't always work out that way. Sometimes you do the scan, and she has the bloods the same day, and then you phone her 2 days later with the result. But the ideal model is if you can give her the result at the same day as you do the scan. That's the ideal. That just requires a bit of forward planning because the woman has to phone up. You have to work out her due date. The scan must be done 11 to 13 plus 6. The bloods can be done 10 plus 0 to 13 plus 6. So the blood is a slightly wider window, but you need to be certain of the EDD. You know, if a woman comes in and has bloods and it comes along for the scan thinking she's 12 weeks and she's only 10 and 11 weeks, the bloods are probably done outside the window. So to do the bloods before the test just requires a little bit of forward planning. It's not always achievable, but that's the aim.
But if you do blood on the same day as
Yeah.
the nuchal transference,
Yeah.
then they can report on the following day when the blood is available.
Usually 2 days, yeah. So they come in on Wednesday, usually Friday morning you get the results. But then you're phoning the patient and she doesn't answer the phone, and then you leave a message. And the ideal thing is to do it all the same day is the best. But we struggle to achieve that in the MFM department in Royal North Shore because it's just too much planning ahead of time. So we tend to do the bloods on the day and phone the patient. Yeah. So in terms of nuchal, because we have to talk about the cell-free DNA, of course. So just in terms of the nuchal, because it's important if we're going to thinking about changing to a new test, you have to remember what's good about this current test, what's good and bad about it. So we pick up 90 to 95% of downs, which put another way is we miss 5 to 10%, but 90 to 95% is very respectable. We can pick up 2/3 of major problems. We might pick up some congenital heart defects, but the false positive rate is 2 to 3%, unnecessary worry for those women, maybe even a CVS or an amnio, exposing the baby to risk for those women. It's not as good for the other chromosomal problems, Edwards and Patows. Obviously, it doesn't give us gender, and this is sort of a driving force for some women now in the private sector, or it doesn't give us a figure as such for Turner syndrome. But the critical thing is the window is short, 11 plus 0 to 13 plus 6 for the scan component. Once the crown rump length's more than 85, you cannot do the nuchal. Okay, so 2016, things have changed. And now we have this new concept called NIPT, non-invasive prenatal testing. What's all that about? The Holy Grail. This is Indiana Jones. This is the Holy Grail. Supposedly the Holy Grail, although we're learning more and more about it, and we're starting to think maybe there's good, it's just you need a balanced approach to this NIPT. So the first thing is that NIPT is not a very good term. That's what we use, but the nuchal translucency is non-invasive prenatal testing, Asking a woman, how old are you, is non-invasive prenatal testing. It's not a great term. So yeah, well, that's screening. If she says I'm 45, you say you've got a 1 in 20 risk of Down syndrome, So lots of tests are non-invasive, but somehow this test has become non-invasive because it sounds better than invasive. But technically, we should probably be calling this cell-free fetal. It doesn't roll off the tongue as well, but it's a cell-free fetal DNA test. And I'm sure you guys have been to talks about this, but effectively, if you take a sample of blood from a pregnant woman, the DNA in her blood is mostly her own, and a small fraction of that DNA will be from the baby, because the DNA will cross the placenta into her bloodstream. So the lab can take the 2 sets of DNA, because obviously the baby's DNA is from mum and dad, so it's not exactly the same as the mother's. They can extract the fetal DNA and they can test it. Now it's important to realize, and critical to a lot of the discussions around this is, it's not actually fetal DNA, it's DNA coming from the placenta. So it's placental DNA. But in the same way as when we do a CVS test, we put a needle into the placenta, we take cells to test the chromosomes. In virtually all pregnancies, the placenta and the baby have the same chromosomes. Same fertilized egg. This bit, remember Langman's embryology, this bit becomes the placenta, this bit becomes the embryo, in virtually all cases. But in a very small number of cases, there can be differences between the placenta and between the baby, and that's important when you start getting into positive results. So we call it fetal DNA, but technically it's placental DNA. And the minimum that the labs need to be able to detect a problem is about 4 to 5%, which represents about 10 weeks. So at about 10 weeks, about 5% of the mother's DNA is fetal, and as she heads towards full term, it increases straight line, and at full term, about half the DNA in the mother's bloodstream is actually fetal. But of course, no one wants this test at 39 weeks, but the further you go on, the more DNA from the placenta or from the baby is there, and the better the test performs. Because if you're looking for Down syndrome, you need a lot of the DNA that has Down syndrome within that DNA. But 10 weeks is the minimum. Okay. The other important thing to remember about this test is that this DNA is unique to each pregnancy, and if you test a woman about 2 weeks after a full-term delivery, none of that baby's DNA will be present. So the half-life is very short, the DNA is cleared rapidly, so if a woman has a 12-month-old boy, and now she's pregnant again, and she's worried about gender, there's no cross-contamination there. So it goes up quickly, it falls off quickly, it's unique to each pregnancy. There's no risk of it overlapping from pregnancy to pregnancy and giving false results. So that's important.
Fragments of DNA.
Yeah, non-cellular DNA floating around.
What's the process of differentiating maternal and fetal DNA?
I think mostly, I'm not a cytogeneticist now or anything like that, but I think mostly the maternal blood is really cellular, where the fetal DNA tends to be more cell-free, and they identify the DNA which is not cellular-based. It's the smaller percentage that identify that as the fetal DNA. But as you'll see with some of the cases I have at the end, it can be a struggle, particularly when you throw twins into the mix, or the mother herself might have a chromosomal issue which sort of muddies the water, so it can be tricky. But I think that's the basis, cell-free versus cellular. Okay, so that's the technology. Amazingly, even though we're only talking about it the last 3 years, the original paper, which is from the Lancet, from the Oxford group, this is back in '97. This is almost 20 years ago. Amazing. But it's taken them 20 years to fine-tune the technology. And they started off looking for male fetuses, looking for a Y chromosome which a woman wouldn't normally carry, or looking for a rhesus positive fetus. So looking for things which were clearly not normal within the mother's kind of bloodstream. And as things have evolved now, we're looking for different chromosomes. So that's the original paper in 97. And obviously 2 decades on now, it's basically been routinely made available in 2011. So for the last 3 or 4 years, we're using it. A lot of patients are requesting it. And the critical thing is, originally, as we'll see, the studies are on high-risk pregnant women. So if you take a population of women who are all 40, there's a 1% risk of Down syndrome and test them. That's different to a population of women who are all 20, who are going to have to screen so many more women to identify Down syndrome. So you can't just assume because a test works well in a high-risk population with a very high prevalence of the disease, it's going to work as population screening. But we're starting to get data through now on low-risk populations as well, and it appears to be performing well. So these are the main tests. This is not exhaustive. There are other tests in Australia, but these are sort of the main players. So Harmony, and I have no affiliations to any of these guys, by the way, but Harmony have had a very effective marketing campaign to the extent that many patients are using Harmony and NIPT almost interchangeably, vacuum cleaner and Hoover. But I mean, Harmony, yeah, it's the same. People talk about Harmony as if that's the test. Harmony is just one brand from Ariosa. Up to very recently, Harmony had to be sent to the States. DHM, Douglas Hanly Moore, obviously a major player in this part of Sydney, were using the Verify test. They've now moved to the Harmony test, presumably for cost reasons. So I don't think Verify, I stand to be corrected, but I don't think it's available in Sydney. It may be available elsewhere in Australia. The Harmony test costs $450. There's no MBS rebate. The processing time is a week, because they're now doing it here in Sydney. And it reports basically low risk or high risk for those 3 main aneuploidies, Downs, Edwards, Pataus, and it looks at the X and the Y. And the benefit of Harmony, I suppose, is supported by that big next study, which we'll look at now. The Genea test, GeneSight, which is also very popular, which was the first test to be processed here in Sydney, so it was a bit of a game changer and sort of first to market in a 1-week processing time, is $445, so basically the same price, analysed locally, 1-week turnaround time, and I often use GeneSight for my patients, and the processing time is 1 week, so they stick to that. And again, they give you 13, 18, 21, and the X's and the Y's. Whether the parents want to know the gender or not is academic. If they don't want to know the gender, you don't tell them. But they always analyse the X and the Y because they need to make sure it's not Turner's or Klinefelter's. So the parents don't have to know the gender, but the test includes the gender. And then Panorama, which we are doing less of, where I work, but is available here in Sydney through IVF Australia, is slightly more expensive. And there are 3 different options depending on whether you want the basic package or you want to include some of the microdeletions, which is a different argument. But it's I think it's 525 is the standard 3 aneuploidies. That's a misprint, up to 825. But this is still being processed in the US. The processing time is still 2 to 3 weeks, which is a lot worse than a week as you know, for a couple who are very nervous. Now, Natera are trying to pitch this that we look for these 5 microdeletions: DeGeorge, 1p36, Wilf-Horst-Shorn, or Creed-Shah, that is, Prader-Willi, and Angelman's. Just 5, almost sort of random microdeletions. And none of unless the woman has a family history, none of the expert guidelines around the world are recommending microdeletion screening in a general population level. So to have an average woman who's 35 come in and say, I want this done. I've recently personally had a woman come back with a false positive Angelman's who went through a CVS, that was normal. It strikes me as madness that at a population level we'd be offering microdeletions, but that's how they're trying to differentiate their test.
So a very low knockdown probability that
yeah, one in
false positive is going to come out.
1 in 80,000. Creed-Shah is 1 in 50,000. Yeah, I mean, we're just testing for it because the test can do it. I mean, the only one there that's potentially useful is DeGeorge. I mean, 22q can be useful in a baby with a heart problem. We do sometimes like DeGeorge syndrome, can be helpful, but this is very controversial, to be testing these these are very, very rare. Anyway, that's how it's different. So there's basically 1, 2, 3.
A year or so ago, when they were first coming into Australia, they
Yeah.
said that the prices were going to come down quite considerably. They don't
Yeah.
look like they have. Has anybody got any idea about that?
I think the price, I mean, I've been in Australia now, most recently the last 3 years. I think these prices, when they first came out 3 or 4 years ago, were $12.50. And then they were $7.50. But you're right, I think it's highly likely in the next few years these will be $250.
Yeah, that's sort of
And that's what people are waiting for, And when that arrives, and it's almost inevitable,
Yeah.
it'll almost become the standard.
Yeah,
You
that's
know,
what I was
almost be
thinking.
part of your booking bloods. But they're holding fast with their 450. Presumably they're happy with their economics and their
Yeah.
uptake at the moment. You know.
Colin, is
Um,
there any talk of a Medicare rebate or any strategic level?
No, I don't think so.
My understanding
I
is-
don't think so. I don't think so. I don't think it's cost beneficial at the moment,
Sure.
and for the population. You know.
So do women have to go to a clinic to get it done the Jenny side?
No, no.
So they can go to DHM and get it sent off?
No, sorry. So for the gene site, so some of the private ultrasound places will offer gene site on site,
Right,
or a Janae will offer it in their labs.
yes.
Okay? Or if we have a patient in the hospital and they need a test, that's the one we use because that's the best deal we got. If you want Harmony, you go to DHM, you get referred, and Panorama is IVF Australia. Yeah,
We
yeah,
use $5 less.
yeah. Minus the bus fare, wherever. So that's just the mechanics. They only take 10 mils of blood. Panorama take 20 mils. Turnaround time is a week for the two sort of big players in town. And gender is routinely available. I haven't seen a wrong gender yet, but it's not 100%. And just be careful with particularly donor egg IVF, twin pregnancies, which I'll talk about, previous organ donation, which is not common, and BMI. The higher the BMI, the lower the fetal fraction. And if you send a woman with a very big BMI, 10 and a half weeks, there's a chance the test could come back in failed draw. Okay, so this, I'm not going to try and make you read this entire slide. I was just trying to squeeze in. This is the International Society of Prenatal Diagnosis. There's a lot of guidelines, but this is a reputable society. So I've just summarized this entire slide, which is all the studies. And every 6 months a new guideline comes out with 3 more references because it's so rapidly evolving. But the overall performance for cell-free DNA testing, and remember what we had for nuchal, we had 90 to 95 for Downs. So for Down syndrome, the detection rate, the sensitivity, the chance the test will find a problem if it's there is 99.5%. That's what I quote to patients. The chance of a false positive, we quote about 0.1%, 1 in 1,000 chance of unnecessary anxiety. It's not quite as good for Edwards, 95, well, it's pretty good. Pate is 85 and Turner's 90, okay? So these figures are better than the nuchal translucency, okay? And these have been consistently shown across different studies.
They're better by an order of magnitude.
Well, I suppose, yes. I mean, 99.5 is more reassuring than 95. What's the chance the test will miss my baby with Downs? 1 in 200 versus 1 in 20. That sounds better, yeah. As long as people realize this is not 100%. A lot of misinformation out there. People going around saying that an NIPT is as good as an amnio, which is far from the case. So it's an advanced screening test. It will miss 1 case out of every 200 with Downs, and it'll miss 5 out of every 100 with Edwards, and similar as you can see. Okay, but these are very impressive figures, and the false positive rates are very low. 1 chance in 1,000 of false positive in singletons, probably slightly higher in twins. Okay, so it works. We know from these studies, these are all high-risk groups. Obviously, when you're testing new technology, you look at the highest risk groups. It seems to work very well. How does it work in low-risk groups? This was the study I mentioned recently. It's from last year, called the NEXT study. It was 35 centers. 15,000 or 16,000 women had both nuchal translucency and cell-free DNA. It was sponsored by Ariosa, so they used the Harmony test in this particular study. They actually excluded twins and donor egg IVF, because obviously donor egg IVF, there's a different genetic profile. You've got the mothers, you've got the donor egg, and you've got the baby, so one has to be careful. So we went through this before, okay, so there was 16,000 women, okay, and this was the graph I showed you before. There was 1 in 200, almost 250 babies, pregnancies had a chromosomal abnormality, okay. So just to have a look at the chromosomal abnormalities, so Downs, the detection, and this is in general population screening. This is not women who are all 40 or over, 35 or over. This is all comers. This is 22-year-olds, 29-year-olds, okay, 31-year-olds, no particular history. They detected 100% of babies with Down syndrome, 90 and 100% of Edwards, okay, and the false positive. So this is basically the same statistics I showed you in the last slide, but a different population, low-risk population. The average person who walks in the door saying, I'm thinking of screening, I'm only 31. So it does seem to perform as well and better than the nuchal translucency for these 3 chromosomal problems, and 3% of tests failed, okay? So it seems like it's better than the nuchal translucency for Downs, seems like it's better for picking up Edwards, seems like the false positive rate is better, and it can be performed any time after 10 weeks, not 10 to 14 weeks. If a woman comes in at 16, 17, 22, 24 weeks, in theory she can have it. What will she do with the information? is a different argument, but she can have it any time after 10 weeks. And gender is becoming a big issue for some couples. But just take you back to this sentence, the parents want to know about the health of their baby, and the sort of model we're starting to see now is a woman having a dating scan at maybe 7 weeks, so her dates are bang on within 5 days, like Talat said. Then she comes in at 10.5 weeks and she has her cell-free DNA test and she says, I'm going to pay $450 to the lab, I'm only going to be pregnant 2 or 3 times. She pays her $450, she gets a result, we phone her in a week and we say the risk is low. They think that means the baby's perfect. A low-risk NIPT means my baby's perfect. And then she comes back at 19 weeks and you do that enough times and you see a heart defect or anencephaly or whatever. So we just have to start remembering when we're comparing the two that the nuchal translucency did offer those other benefits, like picking up other chromosome problems and structural problems, okay? And not all chromosome problems are Down syndrome, and it's felt that overall, almost as many as half of aneuploidies picked up an amniocentesis will not be these 3. It was a quarter in the previous study I showed you. The overall suggestion is maybe a half, okay? I want to just point out, this is not a very sort of impressive slide, but it's a really important slide. It's a different study. It's from the States. But I think this is just a really important slide to remember if you come across counselling women about screening results. I appreciate you may not be doing much screening results. They may come through us. But it's still important that of 1.3 million women who had nuchal, the 5% always shows through. So 5% were screened positive. 26,000 had amniocentesis or CVS, okay? And 3,000 women in this group had babies with abnormal chromosomes, okay? Overall, 1 in 6 of the abnormal chromosome results were atypical problems, not Downs, Edwards, or Pate's. Other things listed on the right. Mosaic problems, so mosaic patterns, some chromosomes normal, some abnormal. Translocations, triploides. So 1 in 6 women whose babies had abnormal chromosomes would have had a normal harmony test or gene site test. So it's just important to remember that, and remember that if a woman goes for nuchal translucency screening and gets a high-risk result and then opts to pay her $450 and have cell-free DNA testing, that can be pretty accurate at telling her baby does not have Down syndrome, but it's not going to tell her baby doesn't have one of these things. Okay? And there's a chance of that.
What do you do in that setting?
Well,
What should we be doing? Because that does happen to us. They have a high-risk Downs.
Yeah.
They opt to have an NIPT.
Yeah.
The NIPT is normal.
Yeah.
What extra should they have?
Nothing. There's nothing extra they can have.
Okay.
I mean, the choice at that stage is before they spend the $450 is the risk on nuchal translucency so high in terms of numerical risk, or is the nuchal translucency measurement itself quite large, because that's considered a structural problem? Does that picture sufficiently concerning to skip the NIPT and go straight to an invasive test? Because we do sometimes see people coming in and they say, I had my nuchal translucency. The nuchal translucency was 5 millimeters, which is quite big. Yeah. I was sent for my NIPT. I've now done lots of reading in the past week and I realize it could be something else, and I'm sort of a bit annoyed I spent $450 and now I just want an amniocentesis. So the stage is when they have the high-risk nuchal, to remember this slide, that of people with high-risk nuchals whose babies have a chromosome problem, 1 in 6, it'll be something you wouldn't see on NIPT. And overall, the risk of having an atypical chromosomal problem in women who get a high-risk nuchal result is 1 in 100.
The problem there is that the NIPT is a screening test and you're trying to use it as a diagnostic test.
Correct. So you're taking a screening result and you're adding in an advanced screening test on top. So you don't get clarity. So you do have to be careful. Now, the patient may choose that. She may say, I'm not taking the risk of an amnio. 1 in 200. I'm 42. This is IVF pregnancy. I don't want any chance of miscarriage. I'm not taking any risk. But it needs to be an informed decision that the NIPT, you're right, is not going to give the same information as an amnio would or a CVS would. You know, that's important. It's not diagnostic. And this is, when I read this was quite surprising, that it was as common as that, a 1 in 100 chance of something unusual. So that's just to make the same point, you know. If you've got a big nuchal or a problem on the scan that we detect when we're doing the nuchal, we don't mess around with this. You should just be going straight into an invasive test, you know. So people probably will be familiar with invasive fetal testing, but just to remind people, we can do a CVS from 11 plus weeks, and we can do an amniocentesis, which is a sample of the fluid around the baby at 15 plus weeks. Both really have the same risk of miscarriage. The studies that suggest a higher risk from CVS, it's probably because CVS is done earlier and the natural background rate is higher. But in the direct head-to-head, one is probably the same as the other, 1 in 200 risk of miscarriage. CVS samples the placenta, which is important because it's not always the same as the baby. And there is this small risk of what's termed confined placental mosaicism. So these are cases where a placenta has a mosaic chromosomal problem, but the baby's actually healthy. And that's important. Sometimes you can have an abnormal NIPT test, and you do a CVS, and the CVS is abnormal, but actually the baby is healthy. So one just has to be careful. If you're counseling patients who've had an abnormal NIPT test, you have to remember that what's shown up the abnormality was placental DNA, and maybe you should be skipping the CVS and waiting to 15 weeks and having an amniocentesis, okay? Okay.
Meanwhile, you're seeing this person every 2 days. Yeah, so anxious about what test.
I know, but every needle carries a risk. So you want to do the best test at, at the right time. That's, okay, so quickly, just because I'm running out of time, because I've talked too long. Quickly to go through special situations. I have a couple of case reports or recent cases I just want to take you through. So what happens if the test fails? This is important. The test failure rate is about 1 to 3%. It's higher with higher BMIs and if you're not sure of your dates, so you want to make sure it's at least after 10 weeks. And if a woman has a very, very big BMI, maybe leave it a little bit longer, maybe 11 weeks. But the important thing is that when they've looked at the cases where the test has failed, within that group, there are more chromosomal problems. So about 3, because a chromosomally abnormal baby is more likely to fail in the lab. We see that with amnios as well. So many people believe if the test comes back no result or failed result, the laboratory will normally offer a free repeat sample at no charge to the patient. But many people would feel that a failed result, if you're certain of your dates, should prompt invasive testing. And by having a failed result, you're immediately in this high-risk group with around about a 3% risk of a chromosomal problem. So just important if they go for a retest that they know that this is an issue, okay? Abnormal chromosomal complements are more likely to fail. And a failed test should sort of ring alarm bells. Why did this fail? Second issue is about twins. And obviously you can do a nuchal translucency in twins, and you look at each twin separately, and you do the set of bloods, and you produce a risk for each twin. In dichorionics and monochorionics, you produce a risk for the pregnancy, okay? Non-invasive prenatal testing in twins is really in evolution, and this is very recent. This study is from March of this year. So this really is only, these studies are only really the last 6 months. But it does seem as if the detection rate is pretty good. I mean, these are small numbers, but it does seem as if this test is pretty good in twins. The chance of the test failing is a bit higher. And the big issue is that you don't get a fetus-specific risk. So if I do a nuchal translucency, I can say that twin 1 has a risk of 1 in 100, twin 2 has a risk of 1 in 1,000. And then if the woman wants an amnio, I can do the amnio on twin 1 only. You just get one result here for the whole pregnancy. It doesn't tell you which twin is at risk. So important to remember, you don't get a fetus-specific risk. Triplets, NIPT cannot be used. There's a nice set of triplets I delivered recently, 1, 2, 3. So they got to 29 weeks. They did very well. Severe preeclampsia. So you can't use nuchal translucency in triplets. You can only do, you can't use cell-free DNA testing in triplets. So you only have one choice in triplets or quadruplets, not that we see that often, which is nuchal translucency. And you cannot do the bloods with triplets. So all they have is they have the nuchal scan, and you do the measurement, and you do the nasal bone, and you add it to the age, and you get the results. The bloods aren't validated in triplets, okay? So triplets never get bloods. Exactly, you're amazing, the Pape talk. And then just the other thing to point out is that this is a new concept. Previously, we never dealt with these sex chromosome problems because we didn't detect them with the nuchal translucency. But the overall prevalence of a sex chromosomal abnormality in the average woman is about 1 in 500. So for most women, that's actually higher than the chance the baby has Down syndrome. You know, if you're 32 or younger, you have a higher chance of baby having a sex chromosome problem than Down syndrome. Yeah, we never talk about that. But we're starting to get some results back. This is a result I had recently of a XXX. So we need to start talking about sex chromosome problems, and whether or not we should be screening the population for sex chromosome problems, that's a different talk. You know, but as part of the test, they are being screened. And part of the pre-test counselling is mentioning to the parents that, do you want gender, yes or no? So when I phone you, I know. But also, bear in mind, the lab has to look at the X's and the Y's because there is a small chance they'll detect a problem in the X's or the Y's. And that's becoming part of my little spiel I give them before I do the test, that we didn't talk about that when we were doing nuchal translucency. Okay, so what happens if it comes back positive, the NIPT? So you send off the result, send them to Genea or to DHM, and you get a fax through a week later saying high risk. What do you do? Okay, this is just, I only have about 10 or 15 minutes. So this is just to remind people, and people know this, but the patients get confused. Sensitivity is detection rate. Sensitivity. What, if my baby has the disease, Down syndrome, what is the chance the test will detect it? Well, it's 99.5% versus 95%. Okay, we're clear on that. And the corollary of that is the test will not detect it. Okay, false negative. That's different to saying if the test is positive, what is the chance my baby has the disease? Okay, so that's sort of post-test probability or positive predictive value. So saying that this is just important to realize, if a woman comes back with a high-risk harmony result for Down syndrome, that does not mean her baby has a 99.5% chance of having Down syndrome. Okay? The chance of that baby having Down syndrome, the positive predictive value of that high-risk result for her depends on the prevalence in her age group and will vary from age to age. So for a young woman, the positive predictive value of a harmony test for Downs is about 50%. So it's a coin flip. For an older woman, it's maybe 80 or 90%. Okay, so it's important to realize in harmony actually make it difficult because on their results they say greater than 99%, which is confusing. So just to point out, this is just graphically from one of the guidelines. A 27-year-old has a 1 in 1,000 chance of Downs. A 40-year-old has a 1 in 100 chance of Downs. High-risk population, general population, 10,000 of each. Okay? You can see that the overall positive predictive value in the lower prevalence group is a third, but it's 83% or higher. Because remember, these positive predictive values, they include prevalence. So it's different to sensitivity. One is coming at it from the test's point of view, and one is coming at it from the patient's point of view. So sensitivity is detection rate, chance it'll be detected if it's there. PPV is chance it's there if the test is positive. And you need to be very clear with the patients, because I've had patients come in saying, my harmony test is positive, I want to terminate. No, you're not terminating. There's only 50% risk. We're going to do a test the baby first. You just have to be clear on those statistics that one is not the same as the other. Okay, and you can see the positive predictive values. This is the table I showed you before from the next study. The positive predictive value for Downs was 80% overall, whereas only 3.5% with nuchal translucency. So if you get a high-risk nuchal translucency, 1 in 250 chance, high risk, there's only a 1 in 30 chance your baby has Downs, whereas it's 80% with the self-read. Does that sort of, people appreciate the difference? You can sort of get bamboozled with statistics, but one is the line you give them before the test, and the PPV is the line you give them after the test comes back positive.
So this means a lot fewer amniocentesis are going to be done.
Say that.
This means that a lot fewer amnios
Yeah,
are done.
they are. There are lots fewer. Sure, hardly doing any. But it also means that of the amnios that we do, the percentage of abnormalities is much higher. So we're doing far fewer unnecessary amnios. About almost 1 in 6 amnios being done in Australia now produce an abnormal result. Previously it was 1 in 300 or something, 1 in 500, because you were amnioing so many normal babies, which is a good thing. Good thing. Yeah.
Will the labs run through the algorithms to give you that test, that risk?
The PPV, positive predictive value? No. There are little online calculators where you go in and you type in the woman's age. You can actually click which of the brand's tests that she had done. I think one is from Chapel Hill in North Carolina. We were just talking about the States earlier. And they'll give you the percentage that particular patient has of a PPV. So you can Google NIPT calculator, and it'll give you the chance. So when she says
the combined NT test, that actually does take age into account. That's one of the factors, isn't it?
the nuchal translucency.
Yeah, the combined,
Yeah.
combined
Yeah.
thing, first trimester screening,
Yeah.
age is one of the factors.
Yeah.
But this one doesn't.
This one doesn't include age because it's looking at the DNA, but if you get a positive result, you go back and think about what was her starting point to work out the risk.
Why doesn't it do that additional, add the two values like you would have done in the combined first trimester screening? Why can't it do that? Like the combined first trimester screening is an algorithm. They punch into the computer with those blood results, the thickness
See,
of the age.
let me show you. So,
Yeah.
so if you look, I don't want to go back through all the slides, but if you look at the harmony result, it's in the pack, and it says high risk trisomy 21, and then it says in brackets greater than 99%. That's actually wrong for that particular patient. That's true of the population.
Right.
It's in Arios's benefit to have it saying greater than 99%. If it says 50%, people say, why am I doing the test in the first place? It's 50%. But age is not factored into that result. But we have to use age to work out the chance of it being an accurate result. You see, the difference is that the nuchal translucency is using likelihood ratios. So the nuchal translucency is taking a woman's a priori risk or starting risk, and then it's taking extra pieces of information like the nuchal measurement and the HCG level and the PAP-A level, and it's multiplying those likelihood ratios, be them positive or negative, to fine-tune the risk. So it's just statistical mumbo-jumbo. This is actually looking at DNA from the baby. So it's sort of coming at it a little bit differently, you know? Or so they tell us. So they tell us. Okay, so I'll quickly go through a couple of quick cases. So you send a woman off, it comes back high risk result. What are the possibilities? It could be a true positive. Baby could have the condition, or the baby could have mosaic trisomy 21. So some of its cells are T21 and some are normal. Or it could be a false positive. The baby is healthy. False positive can mean different things. So there could be an issue in the placenta. The mother herself could have a chromosomal problem. The mother herself could have cancer. Cases have been reported. We've got a case that we're investigating at the moment of a mother who's been worked up for malignancy. Or it could be a vanishing twin, or it could be a genuine artifact. So there's one false positive. False positive means the baby is healthy, but it can be other issues. It's not always insignificant. Okay, so these are real cases from the last few months. Okay, so 37-year-old, she's had a healthy baby, previous miscarriage. She came in, and we did the NIPT for her at 11 weeks. As you can see, she's 37, and it came back a high risk for trisomy 21. So this is the GINEA. This is how you get a GINEA result. It just says either no abnormality detected or it gives aneuploidy. It doesn't give figures. Okay, and it said it was a male. So we rang her, we said, this is the story. So because she's 37, we put our little calculator in and we said the chance your baby actually has Downs is about 70%. We told her we would not allow you to have a termination based on this result, and that's recommended around the world. No one should be making irreversible decisions based on NIPT results. That's agreed. So we offered her the options for CVS or amnio, bearing in mind that an amnio is the best test here because you're testing the baby directly by testing the skin cells, and that a CVS carries a small risk of this placental mosaicism, which is getting a bit technical. But she wanted a CVS done, so we did a CVS for her, and it showed Down syndrome after 2 days, and she had a termination, and we checked the parents for translocation. So the test worked well. She's 37, she paid for the test, she got the results she wanted, she was able to make her management decisions. From her point of view, that's a successful prenatal screening. And that was a real case from a couple of months ago. The next case was a 34-year-old that I saw. This is just after I started North Shore. This is a couple of years ago. She'd had 12 failed IVF cycles. So that's alarm bells. So she finally got pregnant with IVF in Brisbane, I think. It was double embryo transfer, which is unusual for a 34-year-old, but given what she'd been through, they said double embryo transfer. And not surprisingly, she got pregnant with twins, DCDA twins, dichorionic twins. This was her nuchal result. So the bloods obviously work for both twins. You just do the bloods once. But because twin 2 had a bigger nuchal translucency, twin 2 got a risk of 1 in 22 for Downs. So you can see that the background risk is the same because obviously it's the same mother, but the adjusted risk is dependent on the nuchal per twin. So twin 2 got this high risk of Downs, 1 in 22. So it doesn't show that well. But then she was sent and had a harmony test, and it's not a great picture, but this says here, high risk for Downs, and this is the case I was talking about, and it says greater than 99% in the blacked out area. So she came in to us, she's moved to Sydney now, 12 failed IVFs, twins, high risk for Downs, totally freaking out. I've been told there's a 99% chance my baby has Downs. What am I going to do? Am I going to terminate one baby? Do I start again? What do I do? It's terrible. Should I carry on? So we explained to her that's not the case. The chance that one of your babies has Downs is about 50 to 60% based on your age. She was already 15 and a half weeks. We did an amniocentesis. It's always tricky in twins. Do you sample one baby or both babies? Obviously, in this case, you would be tempted just to sample the baby with the bigger nuchal. But if you want to give her the all clear, you want to sample both babies, don't you? But every time you sample a sac, there's a risk, and she's had 12 failed IVFs, so you can imagine. You're a bit nervous doing the amnios on the twins. Anyway, we did an amniocentesis on both twins, sent her for fish and karyotype, and both the babies were totally healthy. Normal female, normal female. So this was an NIPT test that gave her undue anxiety, and she ended up having an amnio anyway, and she probably wasn't a great candidate for the for the NIPT test. She probably should have, when she got this result, it really should have been an amniocentesis or nothing, you know?
They could get sued if they're reporting it's 99% of something,
Yeah.
and it's actually not
Well,
true.
Well, you think that print is small, you should see what's down the bottom in the 6-point font.
But you know, that number is wrong.
They will say that's right at a population level, but that's not an individual patient's level.
Yeah, but it's a patient's report with the patient's name on the top of it. It doesn't say the population information level on that.
Yeah,
So
it's a really weird way of reporting.
It's almost deliberately opaque from the patient's point of view. And she was totally freaked out. And
She would be.
I mean, she still had a 50% risk of Down syndrome. It wasn't like we could say she was in the clear. We had to do the amnio. The amnio, 2 amnios, twice the risk, 1 in 100 risk of miscarriage, which she was obviously happy with the result. But that was quite a good example of someone who probably should have skipped the harmony test and gone straight to amnio. And then this is a more recent case, which is a fascinating case, just in terms of what other things we can uncover. And we're seeing more and more of cases like these, really, really fascinating cases. And really, we need a lot of genetics input. This is a woman I saw only in the last couple of months. She's only young, she's 23. Actually, her first baby had Down syndrome and is about 3 or 4 years old. She brought him to the appointment with her. She had a section with him, got pregnant also with twins. This was spontaneous, not IVF, and had a nuchal translucency test. Obviously, with her previous history, this plays into her background risk. So she was given a high risk for twin 1 of Downs, because even though she's young, this history forms part of the test. So she was given a 1 in 46 risk. The options were discussed: cell-free DNA testing or invasive testing. And she elected for cell-free DNA testing because she didn't want to take the risk of miscarriage with twins. And she got, and you can see the date, I mean, these are very recent. I think this is March or April. She got a high-risk Turners. High-risk Turners, which in 1 or both twins, we don't know. And we know the sex chromosomes are particularly troublesome because obviously the mother herself has 2 X's, so it's particularly troublesome. So what do we do here? So she's got high-risk NIPT for 45X. What are the possible explanations? And we did involve our genetic counselors here. These are the possibles. 1 twin has Turners, both twins have Turners, neither twin has Turners. 1 twin has a mosaic Turners, or the mother herself has a mosaic Turners. She's a healthy woman. She had this sort of vague history of cardiac issue when she was younger. We said the only way to clear this up is do an amniocentesis. She goes, I don't want an amniocentesis. I've got a baby with Down syndrome. I know what you're talking about. I don't want an amniocentesis. What else can you do? We said, well, look, the only one of these we can exclude is if we could test you, do a karyotype for you, mum, and if you're normal, then it's one piece of the puzzle that's off the table. So we tested her, and lo and behold, she has mosaic Turners. So in 20% of her cells, she's 45X, and in 80% of her cells, she's 46XX. So have you got any heart problems? Oh yeah, I did actually have a heart problem when I was younger. Oh God, you better go off and have an echo because you're pregnant with twins. Have you got any thyroid problems? So, you know, this was all new. So this was, you know, we just picked up a maternal aneuploidy. Of course, we still don't know the babies are healthy, but we're assuming that this is the cause of it, you know. So this is the last 2 minutes now. So we know what the benefits of the nuchal are. We know what sort of the benefits of cell-free DNA are in terms of the numbers and the statistics and the chance to look at the early anatomy of the baby versus not looking at the early anatomy. What should we be doing? So what do the Americans say? So this is very recent again, May 2016, this month. So the summary, this is a very 5-page document. The summary from the US, from ACOG, American College, conventional screening, which is nuchal translucency, remains the most appropriate choice in most populations. Parallel screening with multiple screening modalities is not recommended. Now, that's not a woman who has a high-risk nuchal who chooses to have NIPT. That's women who come in, and they are coming in saying, I want both done. I want the belt and braces approach. We should not be doing that. And if a woman comes in saying, I want belt and braces, money is no object, I'm in a fortunate position, she should have her cell-free DNA test, and she should have an early anatomy scan. She should not have the blood sent, because a PAP-A and a HCG and a PLGF add nothing to her screening. So she should have the scan if that's what she wants, and the cell-free DNA. But she shouldn't have parallel screening results, okay? And ACOG say that we shouldn't be doing this new test in twins. They're quite definitive about that. They're saying it's not recommended in twins. We do it in twins, and we are doing it in twins, but they say we shouldn't be doing it. What do the Aussies say? This is RANSCOG. They say if a woman has received a normal or low-risk result from NIPT testing, an additional risk calculation, like using your PAP-A or HCG, is not recommended. So they're consistent on that. Don't do the bloods if they've had a low-risk NIPT test. And they remind us that the presence of a structural abnormality.
Clarify about that first one. Is that just
Yeah.
cost? Why not? Just because it's a waste of money?
Because you're doing a more inferior screening test after a better screening test.
Except for the PAP-A and its particular value of nothing.
You know where I stand on that.
I just thought it was funny.
I don't think anyone is suggesting. People just don't like the idea of not having PAP-As, but I don't think anyone's suggesting we should be doing PAP. But this is important. If the baby has a structural abnormality, and a big nuchal is the most common one, you know, if a baby has a nuchal of 4 or 5 or 6 millimeters, okay, we should remember that that is an indication for invasive testing, okay, even if they've had a low-risk harmony. So you have to remember the limitations of the test, as we were talking about before, you know. So this is my 2 cents. There's lots of models that have been thrown around. This is not evidence-based. This is my opinion, having dealt with loads of these things. This is what I think. This is, if I see private patients, this is what I suggest to my private patients that they should do. If they have a low background risk, okay, and you can debate what low is, I recommend they have a nuchal translucency. If they get a low risk on the nuchal translucency, I reassure them. If they get an intermediate risk, and people use different figures here, but most people around Australia are using this kind of a number, you discuss the option of NIPT. And if they get a high risk result, 1 in 50 or higher, or if the nuchal is big, or if they have a fetal abnormality like an omphalocele or whatever, you discuss invasive testing, okay? That's for the average population. That's what I do. If they have a high risk, so they're older, previous effect, they request, too late for nuchal, more than 14 weeks, you offer them, they have to pay for it, but you offer them NIPT test from 10 weeks. If they get a low risk NIPT, you discuss the option of an early anatomy scan. If they get a no result, you remember that that's a high risk group. Okay, they can repeat it, but maybe they should go straight to invasive testing. And if they get a high risk result, you never let them do anything that they cannot turn back from. An invasive test is mandatory, okay? Ideally an amniocentesis, okay, because the CVS can lend a bit of sort of lack of clarity to the situation. Okay, so the conclusions. The newer test, Harmony, GeneSight, Panorama, better detection for Downs, okay, than nuchal translucency. They must be after 10 weeks. Be careful if the BMI is raised, and be careful with twins. With twins, it just needs a little bit of extra counselling beforehand. Don't forget that the nuchal translucency offers an early scan, okay, and that 1 in 100 high-risk nuchals will have some unusual chromosomal problem, which the NIPT won't show. Okay, don't do bloods if they've had an NIPT test, because you're going backwards in terms of screening. Okay, it includes gender, but don't forget to mention that it could pick up a problem with the gender. Twins are a separate condition, and most guidelines currently, internationally and Australia, support the NIPT tests as first-line screening, okay, only in high-risk populations. I don't think anyone in the world is suggesting that every pregnant woman should have NIPT. Not currently, because the cost effectiveness is not there. That might change in the next few years. Okay. Happy to take any questions. I don't know if I have any time left.
That lady was 21 with a Down's baby.
Yes.
What was the partner's age?
I don't know. The partner wasn't there. She came with her mother. I'm not sure if the partner was the same partner. It's a good question. I don't know the answer. Yes?
How do you keep track of which one is twin 1 and which is twin 2?
Twin 1 is, I was going to say you flip a coin, but that's not true. Twin 1 is always over the cervix. So it's much easier. Twin 1 is the presenting twin. So that's much easier to tell in early pregnancy. So when you do you mean on ultrasound scan?
Oh, what I'm saying is you're talking about twin 1 has one this, twin 2 has one this. What do you,
So for example, if
change your position?
So for example, if you're doing a nuchal translucency on twins, you're right. It's very important to document which twin is which. Okay. So you draw a little picture in the notes, and you say the membrane is going right down the middle, and the twin on the maternal left is twin 1, and the twin on the maternal right is twin 2, or top and bottom. Because remember, you could do a nuchal translucency. One twin could have a big nuchal at 12 weeks. She could go off and think about it. She could come back at 16 weeks requesting an amnio, and the nuchals will be normal. You don't know which twin to sample. So it's very important you document, based on the membrane and the sacs, which one is twin 1 and which one is twin. By convention, twin 1 is the presenting twin. And even though later in pregnancy, the twins can often move up and down, in general, the presenting sac doesn't change. In terms of doing growth scans, and make sure that you're comparing the right twin to the same twin. Yeah. Does that answer your question? Or?
Yeah, I just don't know that much about it.
Yeah. It's tricky later on at 35 weeks. There's arms and legs everywhere, so you have to be a bit careful. Okay, thanks very much.
Thank you.